So now we first start with esophageal cancers of the esophageal cancer, which comes under the gastrointestinal cancers. Okay. Now, what is a cancer? It's a disease that is resulting from uncontrolled growth and division of abnormal cells. So, in terms of is the esophagus, the abnormal or uncontrolled cells mainly come from the epithelium, either come from the epithelium or they come from the submucosal glands. So because it's coming from the epithelium, you get two types of cancers mainly. One is one is squamous cell carcinoma, okay, and the other is adenocarcinoma, because adeno is gland in Latin. So if we think about it again, esophageal cancers are divided into squamous cell carcinoma and adenocarcinoma. Now we go into detail of each of these cancers. And how do we go into detail? The first thing that we are going to talk about for each cancer is their epidemiology, risk factors. What are the risk factors of that patient having esophageal cancers? Esophageal cancer clinically, what does the patient manifest? How do you find that this is the type of cancer the patient has? By diagnosis. Staging is very important to be able to give proper treatment. What does it look like macroscopically? What does it look like microscopically? The precursor lesion of each of the cancers. How does it spread into the lymph node? The treatment and prognosis of each cancer. Okay. Now for squamous cell carcinoma, we have to say, now we have to talk about the epidemiology of squamous cell carcinoma. So always remember that it is the sixth most common cause of cancer related death worldwide, and it's mostly common in Asian countries. It is the sixth most common cause of cancer related death worldwide, most common in Asian countries. Risk factor is mainly if it's an elderly male, then it's a huge risk factor. If they smoke, then it's a huge risk factor. And alcohol consumption is a big thing. Alcohol wait alcohol consumption, and pickled food, they are all huge risk factors. But make sure that you know that it is not HPV related. It is not related to HPV. So if a person has HPV, doesn't mean they have a high risk of getting squamous cell carcinoma. It's not correlated, okay? And then we have, what was the second pointer? Clinical manifestation. We talked about the epidemiology. What is the epidemiology of squamous cell carcinoma? The epidemiology is that it is the sixth most common cause of cancer-related death, mostly seen in Asia. What are the risk factors? If there is an elderly male that is smoking and also drinks alcohol, pickled food, hot beverages, they are all risk factors for squamous cell carcinoma of the esophagus. Now we are going to talk about clinical manifestation of squamous cell carcinoma of the esophagus. Clinically, the patient will have dysphagia. ठीक है? Dysphagia or dinophagia. Dysphagia or dinophagia, chest pain, weight loss, and hematemesis. Okay, so dysphagia is basically you have trouble swallowing. Odinophagia is when you have burning sensation or pain while swallowing. Then you have chest pain as a result of because it's really close to it's in the chest area, right? The esophagus. There are symptoms of chest pain, weight loss, because if you can't eat your food properly, of course you'll lose weight. Hematemesis is when you cough out blood. So you see blood in your cough. These are the main clinical manifestations of esophageal squamous cell carcinoma. Okay. Now we did clinical manifestation. Now we'll do diagnosis. How do you find out? If you see that you have a patient who is elderly, let's say he's a male, he's an Asian male, and he is presenting with these symptoms, the how are you going to prove and how are you going to find the diagnosis that this person has squamous cell carcinoma of the esophagus? The first thing that you will ask them to go through is of cytology or biopsy. By taking out the sample from the esophagus, you will do cellular cytology and biopsy. If it is an early lesion, then you can do chromoendoscopy. But if it is a late lesion and you feel like there is some depth of invasion of the tumor, then you have to do endoscopic ultrasonography. Okay. And if you have to see if lymph node has been involved, how do you check for lymph node involvement? You do CT scan or PET scan. PET scan or CT scan. Okay. So what's the first thing you will do if you have a patient that you suspect and you have to diagnose them? You do cytology or biopsy. Then you do, if you think there's an early lesion, you do chromoendoscopy. If the lesion is late and you want to check the depth of invasion, then you do endoscopic ultrasonography. And if you have to see lymph node involvement, then you do CT or PET scan. Okay, done. Now we will talk about the staging. You'll have to stage the disease in order to give them proper treatment. And you do that by seeing if it is protruding type or it is elevated. Staging in this case is not that important. I don't think it's an important question to be asked, but if it is, then I'll come back to it later. Anyway, gross findings, that is basically macroscopically. What does it look like macroscopically? Macroscopically, it can either be flat or it can be elevated. If it is flat, then it is good, but ulcerated masses, you can remove it easily by endoscopy sometimes, but I'm not that sure about it. But large ones, if they are large, they can sometimes get ulcerated. And always remember that the squamous cell carcinoma of the esophagus, you always find it normally in the middle one third of the esophagus. You always find it in the middle one third of the esophagus. And histologically, no wait, this is macroscopically. What else you have to remember? That it can be either flat or it can be elevated. If it is large, then it is ulcerated. I just rhymed. So it can either be flat, elevated. If it is large, it is ulcerated. Squamous cell carcinoma is found in the middle one third of all cancers, of the esophageal cancer, if it is a middle one third. So automatically, if you do a PET scan or a CT scan and you find the cancer is in the middle one third, then you're going to suspect that it is an esophageal cancer. But which type? Is it an adenocarcinoma or is it a squamous cell carcinoma? You're gonna suspect that it is a squamous cell carcinoma. Okay. Now we do microscopically. Now you took out the tumor, you're watching it under the microscope. What are you going to see? How are you going to say what does it look like? You're going to grade it. And there are three main grades. One is well differentiated. Then you have moderately differentiated. And then you have poorly differentiated. Okay? Now in well differentiated, what's the thing? What's it about well differentiated? That well differentiated tumors look more like Original tissue. Well differentiated means that the tumor is OG. Moderately differentiated means that it is not exactly the same looking, but it looks similar. Similar, but not that well. Poorly differentiated, basically you can't even say that this is squamous cell that this is an esophagus, like when you look at under the microscope, you won't be able to say what type of cancer it is. It is that differentiated, it looks very different. The one thing you have to remember, that if you see a well differentiated squamous cell carcinoma, you will always find keratinization. It's a buzzword. Remember, well differentiated squamous cell carcinoma will have keratinization. That's how you grade it. Now, what is the next point that we have to go through? We did staging, we did macroscopic, we did microscopic. Now we have to do these three. What are the precursor lesions of squamous cell carcinoma? Now, precursor lesion is very important. If you don't say precursor lesion to your teacher, he's going to fail you. Precursor, let me just write PC, not Priyanka Chopra, precursor lesion of esophagus. Which cancer we are talking about right now? We are talking about squamous cell carcinoma. Okay, and what are the precursor lesions of squamous cell carcinoma? Esophageal squamous dysplasia. Squamous dysplasia. Dysplasia. If you don't remember anything, just remember that the precursor lesion of squamous cell carcinoma is esophageal squamous dysplasia. ESD. I don't know how to make you remember this for sure, but always the most important thing I think from in cancers are precursor lesions. So the biggest precursor lesion, not the biggest, but like the precursor lesion of squamous cell carcinoma is esophageal, because it is in the it is in the esophagus. Squamous cell carcinoma में squamous आता है, इसके precursor lesion में squamous आता है. Dysplasia याद रखना पड़ेगा, कैसे रखोगे मुझे नहीं पता, बट करना पड़ेगा. So what is the precursor lesion of squamous cell carcinoma? It is esophageal squamous dysplasia. Okay. Now, what do you see? If this is a slide, and these are the cells, let's say, whatever. Let's say this is the whole slide. Okay. You have to, and this is the lower 1/3 of the slide. This is the middle 1/3, and this is the whole thing, like let's say the upper 1/3. Okay. Now if you find nuclear atypia here, nuclear atypia in the lower 1/3 of this of the slide, and you see keratinocytes that have low grade, that have like low nuclear atypia, then it is a low grade esophageal squamous dysplasia. Okay, but if you see nuclear atypia here, nuclear atypia is here, yeah, then it becomes a high grade squamous esophageal squamous dysplasia. But if you see that it's completely everywhere, then it is very high grade, but there is no word for it. It is a very high grade squamous cell dysplasia, esophageal squamous dysplasia. But then you have to look at the basement membrane. The basement membrane. If the basement membrane is intact, then it is still a precursor lesion. It is still a precursor lesion. And if it is, precursor lesion is PL, bro. I don't know why I wrote PC here. It's PL. Sorry. So yeah, PL, precursor lesion. It is still a precursor lesion if the basement membrane is intact. If the basement membrane is broken, brother, then it turns into squamous cell carcinoma. Okay? That was a lot of talking. Anyway, now we talk about Lymph node spread. Now we talk about lymph node spread. Lymph node involvement or spread, whatever. We finish precursor lesion. We do point number 9, which was lymph node. Now, if you look at how the esophagus looks like, it's like this kind of. Now, don't mind my stomach drawing. It's rough. Anyway, let's say this is the esophagus. It's divided into 3. Now you remember that of course you're eating, so it will go through your throat, and the throat in Latin is cervix. Okay, not the gynecological cervix, but yeah, you get it right, cervix. Then as you go down, you see the lungs. Where and the heart. That cavity is mediastinal cavity or mediastinal space. And if you remember that this portion of the stomach is called what? The cardia of the stomach. That's how you are going to remember that in the upper 1/3, if you find a tumor here, it will drain into the cervical lymph node. If it happens here, then it will drain into the mediastinal lymph node, and if it happens here, then it will cardial lymph node. Make sense? Does to me. If not to you, not my problem. I think this was enough. Mediastinal. Yeah, if you want, you can also remember that you have tracheo, bronchial, lymph node involved here. Okay. Then you do treatment and prognosis. How do you treat and what is the prognosis of squamous cell carcinoma? It is, I think, the same for adenocarcinoma, and squamous cell carcinoma have the same prognosis, and you're just going to say one thing: mucosectomy, esophagectomy, esophagectomy. This is when it is early, this is for advanced, and then if you have lymphovascular invasion, then it has a very poor prognosis. Okay, and I think it's the same for adenocarcinoma. So now let's start with adenocarcinoma. What did I tell you about adenocarcinoma before even we started talking about anything? That it is a cancer involving the submucosal glands. That's why it is called adeno. So first thing we talk about in like how we talked about in squamous cell carcinoma, we started with epidemiology. So what is the epidemiology of adenocarcinoma? What is the epidemiology of adenocarcinoma? That it happens mostly in Western countries. The West, it's an issue of the West. And it generally happens with patients who have GERD. They're suffering from gastrointestinal reflux disorder. That is very sad, but it is what it is. It is life. Then you do risk factors. Risk factors of adenocarcinoma of the esophagus. Risk factor is obesity. Basically, fat people, men, just like in squamous cell carcinoma, it is also adenocarcinoma is also more common in men. Third thing we do about adenocarcinoma is its clinical manifestation, which was again dysphagia, odynophagia, chest pain, and weight loss. Okay, then what was the precursor lesion of squamous cell carcinoma? Question. Let's see how much attention you were paying. I of course know it's esophageal squamous dysplasia. Esophageal squamous dysplasia is a precursor lesion. You can't say cause. Esophageal squamous dysplasia is a precursor lesion for esophageal carcinoma. Which carcinoma? Squamous cell carcinoma. I'm sorry about that. Yes, now we have clinical manifestation. You have dysphagia, odynophagia, chest pain, and weight loss. Now, how do you find out that it is, what's the precursor lesion of adenocarcinoma? Adenocarcinoma precursor lesion is Barrett's. I don't know how to spell it. Let me check. Barrett's esophagus. Esophagus. Very, 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 very important. Now, what happens in Barrett's esophagus? So now, remember the stupid esophagus I drew. This was the stomach. Don't mind me. It doesn't look pretty. Oh my god. Better, I guess. Anyway, we said that squamous cell carcinoma happens mainly in the middle one third, right? But adenocarcinoma happens here. You know, the HCl produced by the stomach here, it kind of goes back and it irritates the mucosa here, and that's where you have adenocarcinoma. You have a lot of goblet cell productions, which causes the squamous epithelium there, the squamous epithelium to turn and like the into mucinous epithelium. Okay, and this change is called metastatic metaplastic, sorry. Okay, now again, let's do this again. What is Barrett's esophagus? Barrett's esophagus is when there is change of the epithelium because of constant irritation of the mucosa, where squamous epithelium changes into metaplastic mucosal epithelium, mucinous epithelium, sorry, where squamous epithelium turns into mucinous epithelium, and this change is called metaplastic change. Metaplastic change. Again, what is Barrett's esophagus? Barrett's esophagus is when you have squamous epithelium to turn into mucinous epithelium because of metaplastic change. And what caused this metaplastic change? Constant irritation of the mucosa with acid. Okay, makes sense now. So, how do you what does it look like under the microscope? It is, first of all, because this is in the submucosa part of the esophagus. Let me go back to this picture here. You see, it is in the submucosa, so it is actually in a little bit of depth. There is some depth here. So sometimes when you do an endoscopy, you will not even realize that that tumor is there. You will, because it is destroying this layer. So early lesions are really hard to detect in this case. So what do? We find it in later. Yeah, and it grows ulceratively. That means it is very, like, it goes deep. If anything is ulcerative, that means it's growing deeply. It grows diffusely, which is bad. It's not localized, it's just growing diffusely. It's just spreading, and it's very infiltrating. It's just spreading, going deep. Okay, now we did that. I think we did macroscopically. This is what it looks like macroscopically. What will you say? It is ulcerative, deep, and frilled and diffusely infiltrating. Now if we go microscopically of adenocarcinoma of the esophagus, microscopically, wait, don't mind my spellings please, microscopically, micro adenocarcinoma. Okay, you have to remember that it can have three types of lineages, and four types of growth patterns. 1 2 3 4. Three types of lineages and four types of lineages, and 4 types of growth pattern. ठीक है? What are the 3 types of lineages? First lineage that can happen is that it can have a gastric lineage. Another lineage that it can have is it can have an intestinal lineage. Third one is mixed. ठीक है? Now growth patterns. First, it can have either a tubular growth pattern, or it can have a papillary growth pattern. It can have mucinous growth pattern, or it can have a signet ring growth pattern. Signet ring growth pattern. Okay, this is important, but I don't know how important. So basically, microscopically, 3 lineages: gastric lineage, intestinal lineage, mixed lineage, which will have a little bit of gastric, little bit of intestinal. Growth patterns, 4 types: tubular, papillary, mucinous, signet ring. Tubular, papillary, mucinous, signet ring. Tubular, papillary, mucinous, and signet ring. Okay. And the treatment prognosis is the same as for squamous cell carcinoma, which we said was what? Mucosectomy, esophagectomy in advanced, mucosectomy early in early lesions, esophagectomy in advanced lesions. Now what should we do is that quickly, if we have it in us, we can recap it. Do you want to recap it? Let's recap it. Now, what was epidemiology of, let's say, squamous cell carcinoma? Is that it's the sixth most common cause worldwide in terms of death. It is most common in Asia, and it is most common in Asia in early elderly men who smoke, drink hot beverages, pickled food, and yeah. So we talked about risk factors and epidemiology. Clinical manifestation: the patient will have dysphagia or rhinophagia, chest pain, hematemesis. Okay. Diagnosis is done by cellular cytology, biopsy, chromoendoscopy in early lesions, and esophageal. No. It was ultrasonography in advanced lesions to check the depth of the lesion. Staging, I skipped it because I wasn't sure about it. Macroscopically, what does it look like? Macroscopically, if it can be either flat or it can be elevated. If it is flat, then and sometimes when it is large, it can also be very much ulcerated. Yeah. Microscopically, what does squamous cell carcinoma look like? Microscopically, squamous cell carcinoma. I'm forgetting something, I guess. Microscopically, squamous cell carcinoma. Yes. Oh, yeah. It has moderate, and poorly differentiated. The well differentiated ones will have keratinization. Yes. And the precursor lesion of squamous cell carcinoma was esophageal squamous dysplasia. Lymph node involvement was upper 1/3 was cervical, middle 1/3 was tracheobronchial or mediastinal, and lower 1/3 was cardial lymph nodes. Treatment and prognosis. Prognosis is not good when there is lymphovascular involvement, but the treatment is good. Treatment is either mucosectomy or esophagectomy, and yes, we are done with squamous cell carcinoma. The other type of cancer was adenocarcinoma. Adenocarcinoma is most common in Western countries, and The risk factor is basically GERD. Clinical manifestation is dysphagia, I think. Then you have chest pain and you have weight loss. Sorry, weight loss. Diagnosis is by, how do you diagnose it? Is by same things: chromoendoscopy, ultrasonography, and cytology is the first thing. Cytology, biopsy. Macroscopically, it is very ulcerated large masses, and it is diffusely infiltrative growth. Microscopically, there was a lot to talk about. There was lineage, there were three lineages, and there were growth patterns, which were four growth patterns. The three lineages were: first was gastric lineage, second was first was gastric, second was intestinal, third was mixed lineage of both gastric and intestinal. Growth patterns were papillary, tubular, papillary, mucinous, and signet ring growth patterns. Then you have precursor lesion, which was Barrett's esophagus. What is Barrett's esophagus? Is when there is constant irritation of the mucosa of the esophagus, which converts a squamous cell into squamous epithelium to mucinous epithelium, and the change is called a metaplastic change. And lymph node involvement, I think, is kind of same, but I don't know, I'm just guessing this one. And treatment and prognosis is very similar. So finally we're done with esophageal cancers. Yay.